When you convene that guideline group, it really needs to be multidisciplinary, right? It can't, guidelines developed by single professional bodies where the panels consist only of people from a single professional body, that's not a great way to go about this business at all. The reason you need multidisciplinary participation is because you need that expertise, right? If someone's doing radio frequency stimulation or involved in spinal fusion or disc replacement or opioid prescription or physical therapy, you need their nuanced understanding of these interventions to interpret that evidence, that subject-specific expertise. You need it because it's multidisciplinary teams that people with back pain are exposed to, so they need to be represented. You need it because in the end, when you publish this guideline and you haven't involved people, if they don't like it, they will reject it out of hand, and the guideline is completely pointless. But by multidisciplinary participation, we are not just talking about clinicians. A guideline that does not include people who experience that condition and experience clinical care just isn't worth the paper it's written on. You need patient representation, and not in a tokenistic way, but a full, balanced voice at the table. And when you bring that multidisciplinary group together, it needs to be very clearly established at the start that there are no leaders in this room. Everyone's voice is an equal vote. The real reason, of course, you need multidisciplinary participation is because clinical guidelines are a political process, right? Everyone wants their territory protected because that's how industries work, professions work. So you need a balance of those interests to try and avoid it being too busily pushed into the interests of one professional group. And I'll give you an example of how that can go wrong. This is a very fresh review of financial conflicts of interest in the guideline panels at the peak of opioid prescribing. So they had a red flag checklist that they applied to guidelines on opioid prescribing. It was things like the sponsor is a professional society that receives substantial industry funding. The committee chair has a financial conflict. Committee members have a financial conflict. Committee stacking that would preordain a recommendation regarding something controversial like opioids. No involvement of methodologists or research experts in the process. No external peer review. No inclusion of non-physician experts, patient representatives, community stakeholders. It's pretty clear. You can see how each of these things might produce a conflict. 13 guidelines on opioid prescribing between 2007 and 2013. Across those 13 guidelines, they found 43 red flags. That's an average of 3 red flags per guideline. This isn't serving people with pain. This is very, very dangerous. Of course, if you're using a guideline as a clinician, you probably want to know if it's a good one or not, if it's been done well, if you can, at least to some extent, put faith in it. And we now have, and this is an internationally recognized quality assessment tool for clinical guidelines, called the Agree To tool. You can download it for free. There's a manual for how to apply it as well. So you take a guideline and you look through different domains. Were they clear about their scope and purpose? Have they clearly outlined and attended to involvement of all stakeholders, including patient groups? Have they used methodologically rigorous approaches to synthesizing the evidence? Have they presented it in a clear way so that the audit trail between the data and the decisions, the recommendations, is clear for people to see and understand? Have they made recommendations that are actually applicable in practice, that could be delivered in that clinical community? And was it editorially independent, or is it full of these red flags we were talking about? Ivan Lin from Australia a couple of years ago did a systematic review of musculoskeletal clinical practice guidelines and found that on the whole, they were pretty low quality. And I'm not doing this as a fact of self-promotion, but the only one that they thought consistently met high quality standards was the 2016 guideline for low back pain. Go us. But it was nice to see because there was a process, and if you go on the NICE website, you can download 3,000 pages of documents that explain how we get there, if you've got nothing better to do. So I think about the NICE process for back pain, and you think about, I want to be an evidence-based clinician. I want to know what the evidence tells me about low back pain. Let me give you a sense of the scale of the task. We had 23 new systematic review questions, and we could answer them with 22 new systematic reviews. That means in the end we screened 43,000 records and 734 papers were reviewed. We received 720 stakeholder comments. People really care about what recommendations are made. And 297 internal review comments from NICE. It took us 3 years to produce the guideline. It runs to 3,600 pages, and we made 41 recommendations for practice and 7 recommendations for future research. And the reason I show you that is just to try and give you a sense of the scale of the task and why guidelines might represent a proxy and a shortcut for you guys when you're trying to make sense of such a vast body of evidence. And after all that work, we came up with this picture. It's pretty, isn't it? But, I mean, most of you will be familiar with the recommendations, and I don't want to dwell on it because this is just our guideline. I think it would be interesting more to look at what the recommendations are across a number of different guidelines for low back pain. Because actually, it's not always consistent. If we look at the UK guidelines and then we look at the US, the APA guidelines, and you look at the Danish guidelines, you'll see differences. There are differences in the recommendations for spinal fusion. At NICE, we said, do not use spinal fusion, do not offer it, unless it's part of a new RCT that can actually reduce the current uncertainty about the risks and benefit. But other guidelines will use the equivalent of a do not routinely use or do not use first. But the evidence for spinal fusion, there is some evidence of some benefit, but it is far from compelling. We said do not use any spinal injection, which made us super popular with the spinal injectors. But you know, the evidence was appalling. It wasn't clearly better than placebo, right? But other guidelines will say do not use it first or do not routinely use it. We said do not use acupuncture because it wasn't convincingly better than placebo, sham acupuncture. Other guidelines have focused on the comparisons of acupuncture to usual care, and on that basis have said, well, you can offer it. We said you might, for a certain group of people near the end of the pathway, use radiofrequency denervation procedures. And other guidelines have said the evidence is currently inadequate. We said do not offer opioids for people with persistent back pain. Other guidelines take more nuanced positions. So why is it that if these guidelines are essentially looking at the same evidence, they're coming up with different recommendations? What are the sources of inconsistency? Well, it depends on what question you ask. We took the view at NICE that if it was possible to do a placebo control for a treatment, we wanted to know if the treatment was better than placebo, and that was our priority question. So placebo controls, efficacy trials, were the ones that we would base decisions on where they were available. Other guidelines aren't interested if it's better than placebo. They just want to know if people feel a bit better after receiving the treatment. And that will lead to differences in recommendations. We did not recommend acupuncture on the basis that it wasn't better than placebo. Other guidelines say we will recommend considering acupuncture because it seems to be better than doing nothing.
Thank you, Neil. Okay, so we're getting some questions. I'm going to just take the top one. So from Kiri, see if I can put it up there. Oh, you beat me. Okay. How different are Scotland's low back pain guidelines?
Not very, actually, but they have their own, because they're devolved, they have their own health system. The devolved, no, that's actually a term, I don't mean they're unevolved. Devolution was the process of Scotland having more control over its laws. You know, a bit like Brexit, but not as stupid. And damaging and nihilistic. Oh, sorry, no, I'm digressing. No, they're very similar. They were a little bit more inclusive, actually. The NICE guidelines are probably, no, they're definitely the most conservative back pain guideline that's been published to date. We recommended much less than other guidelines. The Scottish ones, from the top of my head, they did recommend acupuncture, I think, or at least as a consider. So they obviously took that route of versus no treatment rather than versus placebo.
Okay, and the next question, let's see if I can be more helpful. From Caitlin, why use pain scale for measuring effectiveness or efficacy?
Oh, what a great question. What else should I use? Yeah, so look, I guess I was simplistic there. So the two main outcome, or three main outcome measures. were pain, disability, and health-related quality of life. And then there was cost effectiveness as well. But don't be fooled into thinking that any of this is rationing. Cost effectiveness was not used to drive any of our recommendations. It didn't come into it because there were already other reasons to either recommend or not. So we didn't just look at pain. Pain's the one I use. So we looked at disability measured on the Oswestry or the Rowland and Morris disability questionnaire. And we looked at health-related quality of life. And we looked at adverse events and harms. And yes, we looked at cost effectiveness, so quality adjusted life years and incremental cost effectiveness ratios as well. Pain scales are awful, aren't they? They're still what we got. But they are genuinely dreadful. And I've never been to a patient panel at a conference where one of the patients hasn't quite rightly despaired at the visual analog scale. It's totally suboptimal. But, how do you measure pain? Maybe you don't measure pain. Maybe there are other outcomes you want to measure, but that may be for another day.
Okay, the next question from Dave Walton. Neil, when your group extracts data for the CPGs, do you routinely extract info on inclusion-exclusion criteria too? Do you think the evidence is advanced enough to be able to make separate recommendations based on patient-level variables like sex, age, and other comorbidities?
Right, so a few questions in there, Dave. Thanks very much. But no, they're good ones. They're good ones. So yes, we like you would in any systematic review, the technical team at NICE extracted those sorts of data, the inclusion, exclusion criteria, and everything else. But you've never got enough trials that are consistent enough to really do any formal subgroup analysis that is going to be meaningful, and you'll have. I can't even see where Dave is. Dave, where are you? There you go. Where you're going to really be able to use that to make big decisions or get robust group-specific estimates. So I just don't think we're there yet. I think the other thing, of course, is if you approach it that way after the fact, what you're doing is post hoc subgroup hunting, which I like to call searching for the pony, right? Because if you've got no effect or a very small effect, but particularly if you've got no effect, then you go hunting for responders. Well, you're not measuring responders, you're measuring people who got better for any number of reasons. And you might find a subgroup, but it's a bit like trying to find a pony in a room full of horseshit. So if you want to look at subgroups and if there are specific subgroups of responders, then I think that starts with the primary research. You hypothesize first, you design your trial to do that, and it's got to be big enough to detect an interaction between that variable and the outcome.
Okay, next is Linda Crawford, who's also watching from home. I'd be interested to hear the 7 recommendations for research NICE made.
Oh, God.
There may be potential researchers in the audience.
I can't remember them. Okay, so I really actually can't remember them off the top of my head. I know we wanted a high-quality, sham-controlled clinical trial of radiofrequency stimulation, denervation, because there was some promising evidence. There's no word, by the way, in clinical research more overused and abused than promising. Promising is what we like to call massively uncertain. So we had a good definitive trial of that. I think we wanted a trial of spinal fusion that would be big enough to reduce uncertainty. I think we wanted a good placebo-controlled trial of muscle relaxants because the evidence there was a bit partial. I genuinely can't remember the other 4. But if anyone wants to know, I can email them round, or you can go on the NICE website, and all that information is freely available.
All right, and then a question from Jerry Durham. Yes, but what have the guidelines really ever done for us?
Haven't I just told you? I knew Jerry wouldn't agree with me. What have they ever done for us? Well, there are different views on what sort of evidence should be used to guide practice, and I'm sensitive to that, and I'd certainly have my position, and I suspect it would be pretty different from Jerry's, and that's fine. There's room for conversations on that. But the evidence base around these treatments is massive, and everyone is looking at what research there is from their own perspective, with their own agenda, in a piecemeal, non-systematic, and often uncritical way, or selectively critical. So the idea that you can get a multidisciplinary group of people funded by the state, not industry, allow no industry involvement whatsoever, have 5, the amount of declarations of interest in there, to really try and give a clean and clear audit trail, it saves you a job that you couldn't actually ever possibly do and is more likely than any other system to get you to some reasonable recommendations. I always think RCTs are the least worst way of measuring whether a treatment works, but they're not perfect. And I think clinical guidelines done well are the least worst way, not the best, the least worst way of trying to guide practice. That would be my answer.
Okay, and then I have another one from Nathan Hers. Do you know of any research evaluating adherence to the wait and see for lower back pain? For example, not going to seek other treatment if that's what is recommended. Any tips on how to increase this?
So I get the first part of the question. I'm not sure I understand not going on to seek other treatment if not going on is what's recommended. Okay. Well, we've got lots of data from usual care arms in clinical trials. But the funny thing about doing nothing is what you compare it to. Is there a placebo doing nothing? Can you compare no treatment to no treatment? So it's kind of difficult. But we know that actually there's an amazing systematic review from Majid Artis's group where they basically took a whole bunch of RCTs for low back pain, and rather than seeing if the treatments worked, they just took randomly one-arm data and plotted it over the next, I think it was 10 months. And whatever group you were in, whether it was no treatment, placebo, usual care, meds, exercise, manual therapy, or whatever else, nearly all of those studies followed the same trajectory. So there is a common trajectory for low back pain. Of course, not everyone will experience it. We're talking about on average. And most of our treatments don't shift that trajectory to a great deal. So I don't know how you design that trial, but I think we kind of know the answer to that question. But this is good news. Most people with acute low back pain are going to do great. A substantial portion of people on chronic low back pain are going to do reasonably well for a time, and most people with any low back pain are going to have it again. Death, taxes, and back pain, right?
Okay, and then we have another one since you did finish early. From Jason Erickson, what are your thoughts on clinical practice guidelines being taught within and applied by unlicensed professionals within their scopes of practice?
Oh, so that's interesting, isn't it? So I guess, Jason, what you're asking me is, can people who aren't part of that mainstream community of the licensed professions, should they be using clinical practice guidelines to guide their treatment? Is that the question?
At least being aware of?
Oh, I mean, totally. I mean, anyone who's working with people in pain in any profession, to my mind, should be aware of the evidence for that condition. And if we accept that the guidelines are reasonable and we think that they represent a roadmap for good treatment, then I don't see why anyone working in a clinical environment I wouldn't encourage them to use it. Of course they should, absolutely.
Alrighty, so that's the end of the questions. Good job.
Thank you.
You get to be done.
Thanks very much.
Alrighty, so we're done a little early, so if we could have a little music. Rajam actually had asked me to ask everyone to switch sides of the room, and I totally forgot. So instead of doing that, because I can see a couple looks of terror of like, do I have to move all my crap? We're gonna move instead. So we're gonna put on a little music. And then when we take our break, we're gonna be back at 3 o'clock. Yeah, 3 o'clock. Okay.